discuss the something about epilepsy, RCOG guideline about epilepsy. Okay, the first thing that I would like to tell is about the diagnosis of epilepsy. Okay, so what aspect of diagnosis are specific to pregnancy and puerperium, including the definition of the seizure for the obstetrician, okay, or who should make the diagnosis of epilepsy and epileptic form seizure. It's written here that the diagnosis of epilepsy and epileptic form seizures should be made by medical practitioners with expertise in epilepsy, usually a neurologist. Okay. Secondly, women with a history of epilepsy who are not considered to have a high risk of unprovoked seizures can be managed as low risk women in pregnancy. Now, what is the importance of classifying seizure types and epilepsy syndrome? Women with epilepsy, WWE, their family and healthcare professionals should be aware of the different types of the epilepsy and their presentation to assess the specific risk to the mother and the baby. Now, what are the other conditions in pregnancy that should be considered in the differential diagnosis of epileptic form seizures? In pregnant woman presenting with a seizures in the second half of pregnancy, which cannot be clearly attributed to the epilepsy, immediate treatment should follow existing protocol for eclampsia management until a definitive diagnosis is made by full neurological assessment, and other cardiac, metabolic, and intracranial conditions should be considered in the differential diagnosis, and neuropsychiatric conditions including non-epileptic attack disorders should also be considered. Okay, now coming to the pre-pregnancy counseling and management, the question arises that what are the risks of congenital malformation in the fetus of the pregnant woman with epilepsy, exposed and not exposed to the anti-epileptic drugs? Okay, means what sort of congenital malformations can we expect? Okay, women with epilepsy who are planning their pregnancy should have a clinician competent in the management of epilepsy, take responsibility for sharing the scene around the choices and the dose of anti-epileptic drugs based on the risk to the fetus and control of seizures. Okay. Now, my question arises at what stage is the highest risk associated? Women with epilepsy should be reassured that most mothers have normal, healthy babies, and the risk of congenital malformation is low if they are not exposed to anti-epileptic drugs in the periconceptional period. Okay, so at what stage there is highest risk? Periconceptional period. Women should be informed that the risk of congenital abnormalities in the fetus is depending upon the type, number, and dose of anti-epileptic drugs. Okay, in the periconception period, she should be very careful, and the congenital abnormalities, as far as those are concerned, that depends upon the type of the drug she is taking, the number of drugs, the dose of the anti-epileptic drug she is taking. Okay, now what are the long-term neurodevelopmental outcomes of exposure to anti-epileptic drugs and maternal seizures in infant born to the woman with anti-epileptics, women with epilepsy? Now, women with epilepsy and their partners need to be informed about the possible adverse impact on the long-term neurodevelopment of newborn following in utero exposure to sodium valproate. Okay, so sodium valproate carry a lot of risk. Based on the limited evidence in utero exposure to carbamazepine and lamotrigine does not appear to adversely affect the neurodevelopment of the offspring, and there is little evidence for the levetiracetam and phenytoin. Parents should be informed that the evidence on the long-term outcome is based on the small number of the children. Okay, so we don't have a lot of data available for the carbamazepine and lamotrigine as well as phenytoin and levetiracetam, so we have limited data. But about sodium valproate, it's confirmed that it causes a lot of abnormalities. Now, another question is that to what extent can congenital abnormalities be minimized in women with anti-epilepsy? Okay, first of all, the role of folic acid is very important. All the women with epilepsy should be advised to take 5 mg per day of the folic acid prior to conception, and to continue the intake until the at least the end of first trimester to reduce the incidence of the major congenital malformations. Now, pre-pregnancy folic acid of 5 mg per day may be helpful in reducing the risk of anti-epileptic drugs-related cognitive deficit. The lowest effective dose of the most appropriate anti-epileptic drug should be used. Exposure to sodium valproate and other anti-epileptic drugs, polytherapy should be minimized by changing the medications prior to conception as recommended by epilepsy specialists after careful evaluation of the potential risks and the benefits. Now, what is the effect of pregnancy on the seizures in women with epilepsy? Women with epilepsy should be informed that 2/3 will not have seizure deterioration in the pregnancy. Women with epilepsy who have experienced seizures in the last year prior to conception requires close monitoring for their epilepsy. Now, how should the risk be communicated to women with epilepsy? Okay, it means that what information should be given to women with epilepsy. Women with epilepsy should be provided with the verbal as well as written information on the prenatal screening and its implication, the risk of self-discontinuation of anti-epileptic drugs, and the effect of seizures and the anti-epileptic drugs on the fetus, and on pregnancy, breastfeeding, and contraception. Now, women with epilepsy should be informed that the introduction of few safety precautions may significantly reduce the risk of accidents and minimize anxiety. Now, healthcare professionals should acknowledge the concern of women with epilepsy and should be aware of the effect of such concern on their adherence to anti-epileptic drugs. Now, coming to postpartum management. What are the recommended models for antenatal care of women with epilepsy, and what are the benefits of the joint obstetric and neurological clinics? Women with epilepsy should have access to regular planning antenatal care with designated epilepsy care team, and women with epilepsy taking anti-epileptic drug who become unexpectedly pregnant should be able to discuss therapy with epilepsy specialists on an urgent basis. It is never recommended to stop or change the anti-epileptic drug abruptly without an informed discussion, and all the women with epilepsy should be provided with information about the UK epilepsy and pregnancy register and invited to the register. Okay. Now, what is the optimum method of timing of screening for detection of the fetal abnormality? Okay, what is the importance of an anomaly scan in detection of the abnormality? The answer is that the early pregnancy can be the opportunity to screen for structural abnormality. The fetal anomaly scan at 18 to 20 plus 6 weeks of gestation can identify cardiac defect in addition to neural tube defect. All women with epilepsy should be offered a detailed ultrasound in line with the National Health Service fetal anomaly screening program standard. Okay, and the thing is that how should the woman taking anti-epileptic drugs be monitored to avoid worsening of the seizures? For women with epilepsy taking anti-epileptic drug is the dose escalation better than expected management? Based on the current evidence, routine monitoring of the serum anti-epileptic drug levels in a pregnancy is not recommended, although individual circumstances can be taken into account. Now, what are the adverse effects of the anti-epileptic drug in pregnancy on the mother, and how can they be minimized? Healthcare professionals should be alert to sign of depression, anxiety, and any neuropsychiatric symptoms in the mother exposed to anti-epileptic drugs. What are the risks of the obstetric complications in pregnant women with epilepsy, and including those taking anti-epileptic drugs? Healthcare professionals need to be aware of the small but significant increase in obstetric risk to the women with epilepsy and exposed to anti-epileptic drugs, and to incorporate this in the counseling of the woman and planning the management. Okay, and how should women with epilepsy be monitored in pregnancy? In antenatal period, women with epilepsy should be regularly assessed for the following: the risk factor for the seizures, such as sleep deprivation and stress, adherence to the anti-epileptic drugs, the seizure type and frequency. If admission is required antenatally, women with epilepsy at reasonable risk of seizure should be accommodated in an environment that allows for the continuous observation by a carer, partner, or nursing staff. Okay, another question is that how should the fetus be monitored in pregnancy? What are the effects of anti-epileptic drugs on the corticography? Serial growth scan are required for the detection of the SGA babies and to plan further management in women with epilepsy exposed to anti-epileptic drug. And there is no role of routine antepartum fetal surveillance with CTG in women with epilepsy taking anti-epileptic drugs. Now, what is the role of vitamin K in prevention of the hemorrhagic diseases of the newborn and maternal hemorrhage in women with epilepsy taking anti-epileptic drugs? All the babies born to women with epilepsy taking enzyme-inducing anti-epileptic drugs should be offered 1 mg of the intramuscular vitamin K to prevent hemorrhagic disease of the newborn. And there is insufficient evidence to recommend the routine maternal use of oral vitamin K to prevent hemorrhagic disease of the newborn in women with epilepsy taking enzyme-inducing drug. There is insufficient evidence to recommend giving vitamin K to the woman with epilepsy to prevent postpartum hemorrhage. Another question, what is the optimal timing and the mode of delivery for the woman with epilepsy based on the seizure control? Women with epilepsy should be reassured that most will have uncomplicated labor and delivery. The diagnosis of epilepsy per se is not an indication for the planned cesarean section or induction of the labor. And how should women with non-epileptic attack disorder be counseled in pregnancy, and how should their non-epileptic seizures be managed? An appropriate medical intervention, including anti-epileptic drugs administration and iatrogenic early delivery, should be avoided when there is firm diagnosis of non-epileptic attack disorder. Now, what are the required? What dose of antenatal corticosteroids should be given to the woman with epilepsy on enzyme-inducing drugs? In women with epilepsy taking enzyme-inducing drugs who are at risk of the preterm delivery, doubling of the antenatal corticosteroid dose of the prophylaxis against the respiratory distress syndrome in the newborn is not recommended. Okay, we don't need to double the dose of the corticosteroid. Okay, now what intrapartum care should be provided? What are the risk factors for the seizures in the labor in women with epilepsy, and how can they be minimized? Women with epilepsy should be counseled that the risk of the seizures in the labor is low. Okay, what is the importance of adequate analgesia? Adequate analgesia and appropriate care in the labor should be provided to minimize the risk factors for seizures such as insomnia, stress, and dehydration. These can increase the risk of these seizures. So these things should be avoided. And long-acting benzodiazepines such as clobazam can be considered if there are very high risk of the seizure in the peripartum period. Now, anti-epileptic drug intake should be continued during labor. If this cannot be tolerated orally, then parenteral alternative should be administered. Now, the another question is that what is the optimum management of epileptic seizures in labor? Okay, every obstetric unit should have written guideline on the management of the seizures in the labor. Okay, that is the optimum management. Now, seizures in the labor should be terminated as soon as possible to avoid maternal and fetal hypoxia and fetal acidosis. Okay, that is a lot of importance of it. Okay, in order to reduce the risk of maternal and fetal hypoxia, we should terminate seizure as soon as possible. And benzodiazepine is the drug of choice in this case. And continuous fetal monitoring is recommended in the woman at the high risk of the seizures in labor and following an intrapartum seizure. Okay, and what are the recommended method of analgesia in the labor for women with epilepsy? Okay, about this it's written that the pain relief in the labor should be prioritized in women with epilepsy with options including the transcutaneous electrical nerve stimulation, TENS, nitric oxide and oxygen, and TOX, and regional analgesia. Okay. We should prioritize these options depending upon situation. We have three main options: TENS and TOX and regional analgesia. Okay. Another thing is that pethidine should be used with caution in women with epilepsy for analgesia and labor, and diamorphine should be used in the preference of the pethidine. Okay. If we compare pethidine and diamorphine is safer as compared to pethidine. Okay. Now, what are the effects of induction of labor in women with epilepsy, and do anti-epileptic drugs after induction aging? Okay, about this, it's written that there are no known contraindication to the use of the induction agents in women with epilepsy taking anti-epileptic drugs. Okay, another thing is that what is the most important suitable place of delivery for women with epilepsy? Okay, for women with epilepsy at risk of the peripartum seizures, delivery should be in consultant LUD unit. Okay, consultant LUD unit, that we should remember, with the facilities for one-to-one midwifery care and maternal and neonatal resuscitation. The decision to use water for analgesia and birth should be made on an individual basis. Women with epilepsy who are not taking anti-epileptic drugs and who have been seizure-free for a significant period may be offered a water birth after discussion with their epilepsy specialist. So depending on circumstances, we can offer different things. Okay. And postpartum management. What is the risk of the seizure deterioration postpartum, and how can this be minimized? Women with epilepsy and their caregivers needs to be aware that although the overall chance of the seizures during and immediately after delivery is low, it is relatively higher than during pregnancy. Women with epilepsy should be advised to continue their anti-epileptic drugs postnatally, and mothers should be well supported in postnatal period to ensure that the trigger of the seizure deterioration, such as sleep deprivation, stress, and pain, are minimized. Now, is there any need to modify the dose of anti-epileptic drugs after delivery? If anti-epileptic dose was increased in pregnancy, it should be reviewed within 10 days of the delivery to avoid postpartum toxicity. Okay. Now, what are the effects of anti-epileptic drug exposure on the newborn through the placental transfer and from the breast milk? And how should the babies of women with epilepsy taking anti-epileptic drugs be monitored? Okay. Now, neonates born to the women with epilepsy taking anti-epileptic drugs should be monitored for adverse effect associated with anti-epileptic drugs exposure in utero. Women with epilepsy who are taking anti-epileptic drugs in pregnancy should be encouraged to breastfeed, and based on the current evidence, mothers should be informed that the risk of adverse cognitive outcome is not increased in children exposed to anti-epileptic drugs through the breast milk. Okay, and another question is that what advice should be given regarding the safety strategy and the care of the baby? It's written that postpartum safety advice and strategies should be part of antenatal and postnatal discussion with the mother alongside the breastfeeding and the seizure deterioration and anti-epileptic drugs. And postnatal mothers with an epilepsy at reasonable risk of seizure should be accommodated in a single room only when there is provision of the continuous observation by the carer partner and the nursing staff. Okay, and how should depression be screened for in postpartum period? Women with epilepsy should be screened for depression disorder in the puerperal. Mother should be informed about the symptoms and provided with a contact for detailed for assistance. Now coming to the contraception. Okay, what contraception can be safely offered to the woman with anti-epileptic drugs? Women taking anti-epileptic drugs. Now, certain women with epilepsy should be offered effective contraception to avoid unplanned pregnancy, and copper-containing IUDs and levonorgestrel intrauterine system and hydroxyprogesterone acetate injection should be promoted as reliable method of contraception that are not affected by enzyme-inducing drugs. Okay, so we can offer this method. And women taking enzyme-inducing drugs like carbamazepine, phenytoin, phenobarbital, primidone, oxcarbazepine, and oxcarbazepine and topiramate and acecarbazepine should be counseled about the risk of the failure with some hormonal contraceptives. Women should be counseled that efficacy of the oral contraceptive combined oral contraceptive progesterone only pill transdermal patches which are rings and progesterone only pills may be effective if they are taking enzyme inducing anti-epileptic drugs, carbamazepine, phenytoin, phenobarbital, primidone, and oxcarbazepine and acecarbazepine. All the methods of contraception may be offered to the woman taking non-enzyme inducing drugs, anti-epileptic drugs, for example, sodium valproate, levetiracetam, gabapentin, vigabatrin, viagabatrin, and pregabalin. Okay, women with epilepsy taking enzyme-inducing drugs should be informed that the copper-containing IUCD is preferred choice of emergency contraceptive, and emergency contraceptive pills with a levonorgestrel and levonorgestrel acetates are affected by enzyme-inducing anti-epileptic drugs. Women taking lamotrigine, monotherapy, or oxygen-containing oral contraceptives pill should be estrogen-containing oral contraceptives should be informed of the potential increase in the seizures due to fall in the level of the lamotrigine. Okay, now what is the preferred contraceptive choice in women with epilepsy, and what risk need to be conveyed to help them make informed decision? The risk of the contraceptive failure and the short and long-term adverse effects of each contraceptive method should be carefully explained to the woman. Effective contraception is extremely important with regard to the stabilization of the epilepsy and planning of the pregnancy to optimum level. Okay, now what may be the effect of driving entitlement of women with epilepsy who are pregnant? Women with epilepsy should be informed of the effect of changing of the dose of anti-epileptic drugs on the seizures and its impact on the driving privileges. Okay, and what are the implications of disability legislation for women with epilepsy and health services provider? Health care provider need to be aware of the quality of the legislation in the UK that protect individuals with the disability from discrimination. Okay, so this is all about the RCOG guideline about epilepsy. Thank you so much for your patience.